So this community opioid symposium webinar is school naloxone opioid overdose training presented by Justin Phillips. This is a free educational event brought to you by Northeast Delta Human Service Authority, Louisiana Department of Health, Office of Behavioral Health, and Foundation for Wellness. It is accredited for 1.5 hours for AMA PRI Category 1 credits, ADRA, social worker, general credits, and at this time pending for LPC. So we should have that for you very soon before the end of the day. The financial disclosures, neither the speakers or members of the planning committee have any financial disclosures. Full participation of this presentation is required, and 1 week after this, you will receive an email from info@foundationforwellness.com with information on how to access your certificate. Okay, so a little bit about our speaker before I turn it over to her. Justin Phillips is the founder and executive director of Overdose Lifeline, ODL, an Indiana-based nonprofit focused on reducing stigma and preventing opioid overdose deaths. She was named a White House Champion of Change for Advocacy, Prevention, and Treatment. After losing her son Aaron to preventable overdose in 2013, Justin founded ODL to raise awareness and save lives. In 2015, she led the successful efforts to pass Aaron's Law, allowing over-the-counter access to naloxone. She holds a master's degree in clinical addiction counseling and philanthropic studies. Her background includes a career in public health and child injury prevention, and she continues to provide counseling services. So thank you so much, Justin, for being here. The floor is yours.
Oh, thank you so much. Thank you. Thank you so much for having me, and thank you for the kind introduction. I do have no financial disclosures. And so today we're going to talk about specifically access to naloxone in the school setting because it's really an important place and has been, a bit of a challenge for us in Indiana. And so we developed this course specifically because we wanted the schools to be prepared, but we knew that they didn't want a mandate. And that's the first step we took was trying to make a mandate. So we created this course, which is one of many courses that we have available through our website to help people be better prepared, specific to the audience. So quickly, some of the things we're going to talk about because we think it's important to get like a baseline knowledge that substance use disorder is a brain disease, and then we'll talk a bit about stigma and the negative attitudes toward opioid use disorder specifically and substance use disorder. So, as many of us know, addiction is a treatable chronic medical disease involving complex interactions among brain circuits. Sometimes there's genetics, sometimes there's environment, and an individual's own life experiences. And so individuals with addiction use substances or engage in behaviors that become compulsive and often continue despite the harmful consequences that occur. Substance use disorder is not a choice, and it's not due to a lack of willpower. It's really changes in the brain structure, and it is labeled a chronic brain disease. So it should be treated like all other chronic diseases, diabetes, heart disease, and high blood pressure. The brain is the organ that's affected. So, to be honest, we have 27 million people in our country living with active symptoms of this disease, which is more than any other chronic disease. We have another 21 million people who live in recovery, which is 43 million people affected by this disease. Sorry, it's 48 million. I'm bad at math. And, we just don't talk about it in those ways. We don't have the resources to address this chronic disease the way we have other resources. We don't, respect the profession and all the soapbox things I won't get into today. But we used to think of addiction as a moral failing. There are people who still believe that. But there's plenty of research now to show that it is not a moral failing. There is some physiological dependence on things, but then addiction really is that change, that sort of crossing that invisible line when the changes in the brain occur and it no longer becomes a choice. It becomes hardwired as critical for survival. And as with any other disease, a vulnerability to the disease of addiction varies from individual to individual. There's not really one single factor, but several factors combine to contribute to the development of addiction. One of those factors being age, right? So the majority of those who have a substance use disorder really started actively using before the age of 18 and developed their disorder by age 20, prior really to what we know to be that the brain is not fully developed until the age of 25. So then we add other risk factors. The likelihood of developing substance use disorder is greatest for those who begin use in their early teens, somewhere around 15, we know. If you introduce a drug prior to the age of 15, you're 5 times more likely to have substance use disorder later in life. We know, for example, that 15.2% of people who start drinking by age 14 eventually develop alcohol use disorder, as compared to just 2.1% of those who wait until they are 21 or older. And then we have the contribution of adverse childhood experiences, which some people refer to as ACEs. And these are potentially traumatic experiences that occur from the ages of 0 to 17. ACEs are linked to chronic health problems, substance misuse in adulthood, mental illness, and have been associated with negative impacts on education and job opportunities. There are 10 ACEs which fall within the 3 general categories: abuse, including physical, emotional, or sexual abuse; neglect, both physical or emotional neglect; and the third category accounts for the child's environment and/or the household. So this includes other individuals within the house who may have mental illness, exposure to domestic violence, household substance use, so again, other people within the household, and parental separation or divorce and/or incarceration. So we know from the research that a child who experiences 4 or more traumatic events is 5 times more likely to develop alcohol use disorder, 40 to 50% increased risk of depression disorders, and up to 46 times more likely than the general population to become a person who uses intravenous drugs. So ACEs play a tremendous role in understanding ACEs as we interact with individuals, youth in our schools, and those kind of things is crucial. Chronic diseases often cannot be prevented by vaccines, nor do they just go away on their own. Unfortunately, we know that to be true with other chronic diseases. But with appropriate clinically proven treatment, including sometimes medication, many chronic diseases can be managed and the symptoms put into remission. So let's talk a bit about stigma, because it is a humongous contributor to people's inability to get help. It's a big contributor to why we need to have these conversations with school personnel. So stigma, as defined by Irving Goffman, who was a sociologist, was one of the first in his field to discuss stigma. So in 1963, he defined stigma as the negative attribute signaling that one is flawed or condemned, leading to rejection and avoidance by others. So lots of ways that stigma is spread. Language can be stigmatizing. For example, we should not use disparaging words like disturbed, psycho, or nuts when speaking about someone with mental illness. Stigma can also be propagated in our attitudes and opinions. For example, if we have a perception that the parents of someone with substance use disorder was a bad parent, that's a stigmatizing attitude. Building a separate school for kids with learning disabilities is an example of policies that hold stigma. Insurance companies declining coverage for individuals with type 2 diabetes is stigmatizing access. And finally, stigma can be demonstrated with behavior. For example, the demeaning behavior of healthcare professionals toward those with substance use disorder can act as a barrier to proper care and treatment and individuals' disinterest in asking for help. Stigma can assume so many forms. It can appear as prejudice, myths, stereotypes, disapproval, discrimination, fear, shame, and distrust. For a long time, a very long time, little was known about substance use disorder and was generally viewed as a moral failing. For more than 75 years, science has proven it to be a disease, but systemic and individual bias remains. As many with chronic diseases, the sooner we intervene, the better the outcome. Yet stigma causes patients and families to keep the disease a secret for fear of being judged and marginalized. We're going to hear from Marvetta, who is a person in recovery and works at a recovery home. Now, can you?
What I've learned through my
Yes, we
journey
can
in
hear it. Yes, we can
recovery
hear it.
is that nobody can tell you and nobody can make you quit. You have to want to quit. My stigma was basically shamed myself. And it really didn't matter what anybody else said or anybody else thought. I beat myself up more than anyone ever could. And the only thing I could do is to find more drugs and do whatever it takes to get it. So I can hide that feeling, bury it real deep. So I didn't have to think about it. And I portrayed myself as this strong person and I wasn't. I wasn't. But the drugs made me feel like I was, and I didn't have to deal with my shame. And I didn't have to deal with anybody who thought anything about me. When the ladies come in here with that shame, with that stigma, what really helps them is to see that someone else has been through it and has made it. The first thing I do when a lady comes to Seeds of Hope is I give them a hug. And I tell them that everything is going to be okay. And then they look at me like, oh, I want to talk to her. She's the director. But once they sit down and they talk to me and they realize that I've been through a lot of what they've been through, and I'm not any better than anyone else. I'm just like them. We were in the same boat. And to give them that nice big hug and to let them know that they're safe and everything is okay and that they can talk about what they've been through, because some people feel, there we go with that word again, shame of talking about what they've been through. Well, guess what? All my staff here at Seeds of Hope has been through it too. If I haven't been through it, then maybe another one of my staff members have been through it. And that gets the ladies to relax, to be able. My name is Marvetta.
So what we hear from Marvetta is, that it's what's the name too? What we hear from Marvetta, I apologize for the technology, is that stigma affects all of it, right? It generates fear, guilt, and shame within the individual who's using. It makes it very hard for us to be willing to be honest about what's happening. It creates isolation. And it's very hard unless we can find a community, the way Marvetta mentioned, of other people to get help. And so it affects our early diagnosis and treatment. We know that people go almost 10 years before they get any help. There's a lot of stigma around how we're managing our disease. It increases complications and it leads to early death. And then finally, as I already mentioned, there's insurance barriers and we don't have the research and funding to address this chronic disease. And then we know that the family and the loved ones experience as stigma by association also makes the family, the community, the school system, the stakeholders unwilling to acknowledge that there's an issue and ask for help. They carry their own guilt and shame affecting their own health and wellness.
My name is Matt Hest.
I'm going to skip that video in the interest of time. One of the most substantial reasons why addiction is stigmatized is because most people don't understand it. And so it's perfectly appropriate because we fear what we don't understand. And when it comes to addiction, people don't really see it as the disease that it is. In fact, as I mentioned earlier, most people consider it a moral failing, and we know even from most recent research, 76% of Americans still see it as a moral problem. And this contributes to outrage around government spending on treating people who have addiction, which actually is cost saving, but no one can really understand that. So the things we can do to remove stigma are to look at how we actually view it, right? What is our attitude? Educate ourselves, educate the community, use what you know to take it into those places where you know people are still approaching addiction as a moral failing. Look at policies. What can you do to affect policies? What can you do to create a recovery community and focus on things like Recovery Month in September? And then, of course, pay attention to the words that we use. You know, hardly anyone, unless we can change the name of the National Institutes of Drug Abuse, right? But we're really trying hard to say substance use disorder, opioid use disorder, not even using misuse anymore, and definitely not using abuse. We really want to talk about that a person had a setback in their treatment as opposed to a relapse. You know, this is the only chronic disease where we kick people out of treatment because they had a setback. What happens in other chronic diseases is that we readjust the treatment plan. And so these are some of the things that we need to do. And so now let's look specifically at what we can do in the schools and how we can help the schools. So it's necessary for the schools to have an opioid emergency response plan and preparedness. And so how can we help them recognize the signs of an overdose and then appropriate ways to administer the overdose reversal drug naloxone? So we know that we've lost a lot of people to this chronic disease. Between 1999 and 2024, this drug overdose has killed more than 1.3 million Americans, and that number exceeds the number of all the U.S. wars combined. Every day in 2024, 220 Americans died from a drug overdose, and that's somebody dying every 5 minutes. For those that don't know, because we don't need to know, I certainly didn't know, this is the family of opioids. So heroin and morphine, hydrocodone are all an opium. Some are synthetic, some are fully synthetic, some are natural. Some are very strong, like fentanyl, which is 50 to 100 times stronger than all the other opioids on the screen. Regardless of the form, opioids are addictive, physically addictive within 3 to 5 days of using them for legitimate reasons, which means any one of us can become physically dependent, which will sometimes lead us to taking more than we should, taking for longer than we should, which is why we've sort of found ourselves in this conundrum in our country with individuals with opioid use disorder. And then important to talk about fentanyl because there's some misunderstanding around fentanyl, but also some awareness that needs to occur. Fentanyl's been around as a drug in the opium class since 1968, primarily used for surgery and pain management. But now illicit fentanyl is the primary driver for the overdose health crisis. And it's cheaper to manufacture, the components are easier to require, and a small amount goes a long way. So that's why we've been finding fentanyl in almost every illicit drug purchased on the street. Nora Volkoff of the National Institute of Drug Abuse has said that it's rare to find people who only overdose on cocaine or who only overdose on methamphetamines. Fentanyl is being used to lace every illicit drug because it's very profitable. In 2022, 6 out of 10 of the 115 million counterfeit pills seized by the DEA contained a lethal dose of fentanyl. And unfortunately, fentanyl overdose is the #1 cause of death among Americans aged 18 to 45. But there's myths, as I mentioned, around fentanyl that I think it's very important for us to cover. So the first myth is that you can overdose just by touching powdered fentanyl. And this is not actually true. You cannot overdose simply by touching powdered fentanyl unless you have a big open gaping wound on your hand when you touch the fentanyl, because it must be introduced into the bloodstream or mucous membrane for someone to feel the effects. Dissolving the powder in a liquid does not change this property. Wet objects do not pose an increased risk for overdose caused by casual exposure. Symptoms such as alertness, rapid heartbeat, hyperventilating, sweating, chills, numbness are not typically associated with an overdose, though they may need medical attention. These symptoms are more commonly associated with anxiety or a panic attack. So really, this health crisis began in 1999 and continues more than 2 decades later. 2018 was the first year to see a decrease. And then, of course, we had the unfortunate pandemic, which caused us to report a 30% increase with nearly 92,000 lives lost. 2021, 106,000 lives lost with a similar increase. And then finally, we're starting to see a decrease in overdose-related deaths. So now we're seeing a 23% decrease over the prior year. It's still the leading cause of death, which is preventable. In the United States, in 2024, 80,499 Americans died from a drug overdose, and this is more than guns or homicides combined. 68% of all of those overdose deaths were opioids, and 88% were due to fentanyl. So here we can see this map of the US and look across the trends in 2024 as reported by the CDC. The darker the blue, the higher the rate of overdose deaths for that state. So in 2024, the US reported a 21.2 overdose death rate per 100,000, which is down 32% from 2022. 48 states saw a double-digit decrease. The states with the highest rate per 100,000 all reported decreases: West Virginia, Alaska, Nevada, and Washington. United States that reported the largest year-over-year increases were North Carolina, up 44%, and Alabama, up 30%. Contributors to the decrease in fentanyl opioid overdose deaths include increased access to naloxone and harm reduction tools, improved access to medication for opioid use disorder, and U.S. law enforcement and international collaboration efforts to disrupt fentanyl supply chains. So this slide shows the youth and young adults ages 15 to 24 rate per 100,000, because we really saw an increase in 2020 of 49%. And since 2022, overdose deaths for young adults has been decreasing, with a decrease in youth the same as overall numbers of 41% in 2024. But the only way we're going to really make a difference for these youth is by talking to them, having prevention education in schools, talking to parents and caregivers about the reality of fentanyl in almost every illicit substance. The challenge that we're having with youth is that they're hearing an Adderall is a good solution and a Xanax is a good solution, and they're purchasing those things, and those things are really not Adderall and Xanax at all, but actually illicit fentanyl. So here's some resources if you're interested. I think everyone's getting the slides after the presentation. This slide shows all of the 8 proven solutions that we've known about since the beginning, sort of this opioid public health crisis. So as you can see, there are some that are policy related, like data and prescription drug monitoring, and some of them that are related to education and awareness, like reducing the stigma of addiction. So now we're going to just look at how to assess and identify the signs of an opioid overdose. And this video is really the reason the presentation exists. So somebody please let me know if you can't hear the audio.
My name is Amy Powell, and I am from Indianapolis, Indiana. By profession, I'm a registered nurse, and I have been a nurse for almost 30 years. I'm very fortunate to have a very tight-knit family. My parents live down the street, my sister, my brother. And I have to tell you, I mean, we thought, raising kids is hard, and it truly does it takes a village. About my boys, I have 3. Ben is the oldest, and he's 26. Max is my middle. He's 22, and Cameron would have been 20. He was a huge dog lover. Cameron participated in a lot of sports. He was the goalie for soccer. He didn't quite have the physique like his older 2 brothers to play football. That's my beautiful boy. Cameron's history with substance use, I think, started in a pretty innocent way. He, like many, started smoking pot, and which, no, I wasn't happy about it, but I thought, okay, that's much safer than alcohol or pills for sure. Cameron had attended a private school in Indianapolis. Cameron actually ended up getting expelled from that school for a one-time use of marijuana in the bathroom. My husband and I shared with the administrators Cameron's very fragile state of mind at this time. He had written a note of self-harm. He was put on Prozac, suffering from depression, anxiety. And the last thing the dean said was, Cameron, you're going to have to answer to this expulsion every time you apply to go to college. We walked out with our heads high, but Cameron left there, and his drug use just spiraled. Fast forward even, another couple of weeks, he had been complaining that he wasn't feeling well. He was complaining a lot of nausea, and it still just never hit me. I just thought he was anxious because he'd been put on Prozac back in October for the note that he wrote, and, he was getting counseling. So I just thought it was a mixture of things. And then that Friday, he went to school. He had taken a pill. He was probably trying to get Xanax, and it was laced with 3 different kinds of fentanyl. He overdosed at school first, and they didn't recognize it because the teachers had not been educated. They did not carry Narcan and Naloxone, which is the generic name for it. They called my mom to come and get him, and they sent Cameron home with my mom. And later that night, he took another pill, and the last thing my mom saw before she went to bed was she opened the door and Cameron was lying on his back snoring. And being his mom, I knew that Cameron did not sleep on his back. He never snored. So these are things that a mom knows, but a grandmother doesn't. And when she opened the door at 6:30 the next morning, he was gone. I think the bottom line is that we need to be much more open as a society about mental health leading to substance use disorder. You've got every opportunity in the world every day to make a difference in the lives of these kids. If you're around them, you hear what they talk about. They're still looking to all of the adults in their life to protect them. And it's better to be safe than sorry, whether it be a teacher, the principal, a parent, a coach. anyone that feels comfortable, administering a nasal spray to a suspected overdose, that would be tremendous. Aside from the EpiPen, I guess, naloxone is probably one of the easiest things to learn to use. Anywhere that we have AED devices, we should have naloxone. I hope by sharing Cameron's story and seeing my face here on camera that I am just a regular person. I'm a mom of 3 boys. I'm a nurse. We've got a great family support system that I'm so grateful for, and it happened to us.
A little hard to watch, but in hopes that those who need to be convinced that it can be in your school, it can be with those good families, it doesn't discriminate, and it's important to recognize it and respond appropriately in the same way we would any other medical emergency, right? So, because it's a life-threatening situation and it requires immediately emergency attention. Basically the central nervous system is affected by the drug, and respiration systems are depressed and breathing slows or stops. Amy mentioned that her mom, heard snoring from Cameron, and that's one of the very first signals of somebody potentially overdosing. And it's important to recognize those signs, have naloxone, and of course we need to call 911 because there may be reason to have more naloxone. So some of the main symptoms of an opioid overdose are, as I mentioned, that snoring, vomiting, gurgling, or choking noises. The person's unresponsive. They may or may not respond to a sternum rub. They won't necessarily be breathing, or their skin may have started to turn blue. So the first thing we're going to do is call 911, and then we're going to administer naloxone. So we make this available so that it's easy to understand that it's FDA approved. It doesn't work on anything other than opioids. It's also not going to cause any harm if there's no opioids in the system. It's been used in the field for 40 plus years. It's used in medical settings when someone has too much of a medication, right? It's to counteract literally an overdose of an opioid medication. It can't be misused, and it's not Suboxone or Naltrexone, which are medications for opioid use disorder. So naloxone is an opioid antidote, which is an antagonist that reverses an opioid overdose. It's easy to administer and store, and it's effective in preventing opioid overdoses. When a person is overdosing, their central nervous system and respiratory system is depressed or breathing slows and stops. Naloxone merely goes into the brain and blocks the mu receptors, kicks the opioid off and blocks it, and reverses the overdose. Again, as I mentioned, it's completely safe. It can be given safely to people of all ages, and it has no side effects, and it will not harm someone if opioids are not present. Also won't work, right? However, naloxone is effective on fentanyl, and so sometimes you hear that it's not, but it is. It's just that it may take repeated doses of naloxone to work. So these are the different mechanisms by which naloxone is delivered. We have intravenous in the hospital, intramuscular, which requires a syringe, and intranasal. And the intramuscular version, apologies, is actually more effective because it goes directly into the bloodstream, and also less expensive, but also intimidating because you have to draw up into a syringe. So as I mentioned, opioids act by binding to one's opioids receptors in your brain and cause them to activate. An opioid overdose occurs when too many opioids or too high of a concentration, for example, with fentanyl, bind to the opioid receptors and tell the body to slow down the central nervous system. So naloxone comes in, kicks the opioid off the receptor and blocks it so that the overdose is reversed and the individual can return to breathing and consciousness. Symptoms can occur again. So in other words, naloxone has a shorter half-life than the opioid, so it can wear off and the opioid can reattach, which is why we need 911 medical intervention, because we may need more naloxone. We may need to go to the hospital, right? So lots and lots of people are at risk of an overdose. As I've said already numerous times, any pill from the street or from social media will carry a high counterfeit risk and likely will contain fentanyl. We had an instance here in Indiana at a school where a student had a vape and something fentanyl related was in that vape liquid and caused him to overdose. And luckily that school had gone through this training with us and was able to save his life. But lots of people are at risk, right? So when we go to the schools and we talk to them about, why they need to have this program, why they need to have access to naloxone, we always tell them, well, maybe it's the visitors, coming for a sporting event, or maybe it's a staff member who, forgot they took their dose and they take another dose. Like lots of us are at risk for taking too much medication, having an adverse effect to a medication. This is the number one side effect to an opioid: respiratory distress. So lots of ways you can access naloxone depending on your state and your laws. They vary from state to state, but most laws now have Good Samaritan protections if you administer to a stranger, and standing orders that allow for access to naloxone without a prescription. We also know that Narcan, the brand Narcan, is available over the counter. So now we'll talk a little bit about what it looks like to reverse an opioid overdose. Just a little warning that this will be depicting an overdose, so if that's traumatic for anyone, I encourage you to look away.
Administering naloxone is a critical step in saving the life of someone who may be experiencing an opioid overdose. The person does not need to be breathing for naloxone to be effective. After administering naloxone, CPR and rescue breathing should only be performed if you are trained or certified. Confirm the overdose by trying to wake the person and observe for the following symptoms. Check for unresponsiveness. Their body may feel limp. Their skin might be cold and clammy. Lips or fingernails may appear purple or blue. Look for signs of distress. They may be vomiting, gurgling, or making choking noises. Breathing or heartbeat may be slow or stopped. Call 911 and ensure that emergency services are on the way. Open the naloxone package by peeling back the tab. Hold the naloxone device with your thumb at the bottom of the plunger and place your first and middle fingers on either side of the nozzle. Gently tilt the person's head back and provide support under their neck. Carefully insert the nozzle's tip until your fingers touch the bottom of their nose. Firmly press the plunger to administer the entire dose into one nostril. Move the person onto their side and into the recovery position by extending the arm closest to you at a right angle, palm facing up. Use your free hand to bend the person's knee that's furthest away from you into a right angle. Gently roll the person onto their side by pulling the bent knee towards you. The bent arm should cradle their head. Ensure that their bent leg remains at a right angle and make sure their airway is clear of obstruction. Allow some space and closely monitor them. If there's no response after 2 to 3 minutes, additional doses of naloxone can be administered every 2 to 3 minutes, switching nostrils until help arrives. Following naloxone administration, the individual may start to wake up. Pupils may begin to dilate, respirations may begin to increase. They might feel disoriented, scared, or nauseated. Naloxone often leads to withdrawal symptoms, which can be distressing. These symptoms may include chills, excessive sweating, fever, intense pain sensations, nausea, muscle cramping, anxiety, and a racing heart. It's important to give the person some space and avoid physical contact, as even a light touch can be painful during withdrawal. Comfort the person and explain what just happened. If police or emergency responders are present, let the individual know they are there to help and reassure them that they are not in trouble.
So these are the individual steps, which I think in the interest of time, I'm not going to cover. So, because I think it's pretty simple, right? You open the package and you hold it and you put it in their nostril, and this side recovery position, I think, is the most complicated part. And that's just so that they don't choke should they vomit. But just as a reminder, the person doesn't have to be breathing for it to be effective. You may need a repeat dose within 2 to 3 minutes. And then if you know how to do rescue breathing, would be actually more beneficial than CPR, but only if you're trained. And then I think the post-administration part is important. So as I said, the side recovery position, but then also understanding that combativeness is not really what's going to happen, but the person is going to be confused. They didn't know that they overdosed and were essentially not alive. They think that they took something and they were having a good time. So that's that piece. And we know that the lower the dose of naloxone, the less likely those withdrawal symptoms are going to occur, which is why you really want to wait those 2 to 3 minutes, even though it feels like forever. And some of the higher dose overdose reversal agent products are going to also increase those adverse symptoms. So as I mentioned, within 2 to 3 minutes, you can give another dose. You will see them return to breathing. There may be that withdrawal symptoms occur and the person may be confused. So as she said in the video, giving them some space, trying not to touch them, helping them understand if EMS is there, that they're there to be helpful. As a reminder, naloxone does not encourage people to use more drugs. It only acts as a bridge between the call to 911 and when help arrives. It allows an individual to stay alive. It doesn't have any effect on a person who's not experiencing an opioid overdose. You may need to give another dose within 2 to 3 minutes. And again, it has that shorter half-life than the opioid. And so there is a risk of re-overdosing, and you want to follow packaging instructions as it relates to expiration and storage. So some frequently asked questions: can you administer naloxone if you don't know what the person took? Absolutely. It's not going to have any effect if there's no opioids, but it's not going to cause any problem. Once an overdose has occurred, how much time is there? That's hard to know. It's a case-by-case basis. So I would always just administer the naloxone, followed by rescue breathing if possible. Apologies. What happens if my naloxone is expired? So there is an expiration date that's required under FDA guidelines, but we know through research and some articles that we have on our website that the efficacy of naloxone lasts a long time. So it's no problem to administer if you have an expired dose. And again, same with extreme heat and cold. It's a liquid, so it could freeze. So if you believe it's frozen, you would want to try to thaw it with body heat, but there's evidence to show the efficacy is still fine unless it's been exposed to very strong high temperatures. And again, I touched on this already, but naloxone does respond to fentanyl. It's just that it's not going to respond as quickly to fentanyl because it's so potent, and also any other drugs that might be mixed in, including benzodiazepines and xylazine. Naloxone will not work on those drugs. So what is the school's role? everyone has been affected, and the more we're preventing and prepared, the better off we'll be. So schools and universities need to be prepared. Staff should be informed of the preventative measures that they can take to reduce non-prescribed opioid overdose in their students and young adults. And I mentioned at the beginning, that we worked with the School Nurse Association. They preferred that we did not have a mandate, but rather a voluntary situation. So they agreed that the safe and effective management of opioid-related overdoses in schools must be incorporated into the school emergency prepared and response plans. So we need to consider who's at risk for opioid overdose, and this can include the guests, as I mentioned, the staff, and the students. Another consideration is, where can the naloxone kits be stored? It should be easy access for the emergency, so it could be locked in any location, maybe where an AED machine already is, or emergency first aid resources. It could be the school administration, the nurse's office, campus health center with school safety personnel, school resource officers. Maybe, depending on how far away the athletic building is, we want to consider putting naloxone out there, again, for those guests. Other considerations include the process for obtaining the naloxone, what is available within each state, what are the resources perhaps for access to free naloxone, what's the protocol for naloxone storage and maintaining inventory, what's the administration protocol, and how will incidents be documented. We also want to consider the staff that are going to be trained, and how are we going to communicate to parents about the fact that we're making this available within our school. And this will probably require input from the nursing medical staff, safety personnel, administration, and other stakeholders. So this was a piece from the USA Today in 2020, believe it or not, and motivated by the incident and rising adolescent overdoses nationwide, this school district decided to stock naloxone, and then they actually had a student overdose, and it made the national news. And this was in Arizona. And I would say that since we've had this initiative in our state, and we partner with other states with this training, we have had incidents where the school was able to respond appropriately and save the young person's life, which is always the only goal that we ever have, right? So hopefully I did that fast enough that we have time for questions, and I apologize if I spoke too fast. This is our website, overdoselifeline.org, and I'm happy to answer any questions and provide any additional resources.
So I'm going to look in the Q&A first. Okay, somebody asked, during Ms. Powell's video, she spoke about different kinds of fentanyl. Can you elaborate about the different types of fentanyl? I didn't know that there was more than one kind.
There are different, what they call analogs of fentanyl, and I'm not a chemist, but what I understand from the epidemiologists and the chemists, and somebody else maybe can say this better than I, is anytime they change one sort of component within the analog, it changes the analog of that fentanyl. So it's about trying to improve on the product, or maybe leaving one ingredient out because they don't want to spend the money. I mean, you have to remember, these are the illicit manufacturers of these drugs, not true pharmacists.
Okay, let's see. Someone said this question gets asked a lot, but can you explain cannabis sprayed with fentanyl?
So chemically, you cannot smoke cannabis and fentanyl together. They burn at different temperatures. So when we hear of cases of individuals overdosing from marijuana and or cannabis, it's probably in a vape or a liquid type form, and not in a smokable form because they burn at different temperatures.
There aren't any more questions in the Q&A, but I can wait a second if somebody else wants to type one in. Somebody in the chat did say, which you kind of covered, if you could talk about a type of fentanyl, pink fentanyl, but you had kind of said you don't know too much about the different. Okay.
Yeah, I mean, I think that they're again, there's controversy around using the term poisoning because in my humble opinion, as the mom who lost someone and who works daily with other parents who've lost, these drug dealers are not our friends, but I don't think their intention is to kill anyone. They're trying to get customers. And they want you to like what they have. And so the stronger the drug they give you, the more you're going to like it and come back and get more. And they don't know what they're doing. They're not chemists. To be a true chemist, you have to have equipment to mix the drug appropriately. They don't have that. So that's really, they're putting food coloring or they're dyeing it to make it look attractive.
Okay. Somebody else said, I've been told fentanyl can be put in anything kids consume. What should kids avoid accepting from other kids at school?
Well, I think that they should avoid accepting anything from other kids, and that parents and caregivers should be willing to have a conversation about that and consider talking about fentanyl test strips, right? So a fentanyl test strip is a harm reduction tool that tests for presence of fentanyl. So when we go into the schools and we do the prevention education program that we have for youth, we talk to them about that, and we talk to them about fentanyl test strips, and we've had students come to the presenter afterwards and ask to confidentially test something they've gotten from a friend. And then the presenter has been able to do that with them and uncover. So these are hard conversations for parents and caregivers to have, for schools to have, but it's where we are right now in this current climate, right?
Okay, and that's all the questions I had in the Q&A. But we want to thank you for presenting.